Good morning, ladies and gentlemen. My name is Dr. Ron Perry, and I am one of the HPV fellows at Mayo Clinic. Gallbladder cancer and intrahepatic cholangiocarcinomas are highly aggressive and lethal malignancies where surgical resections offer the only meaningful chance of cure. Complete tumor removal with negative margins and adequate portahepatis lymphadenectomy for tumor staging is the surgical standard of care in resectable cases in order to provide the patients the best chance of cure or long-term survival. Laparoscopic liver resections have gained increasing acceptance for surgical treatment for both benign and some malignant liver tumors, mostly colorectal liver metastases and hepatocellular carcinomas. Having said that, the safety and oncological adequacy of laparoscopic liver resections for both gallbladder cancer and intrahepatic cholangiocarcinomas have been questioned in the past, and many surgeons were hesitant to consider it, mainly due to safety issues, the challenging nature of these procedures that mandates advanced laparoscopic skills, and concerns about the oncological adequacy of laparoscopic resections for these diseases, and more specifically, concerns about complete tumor removal with appropriate negative margins, tumor cell dissemination, and adequate portahepatis lymphadenectomy. Laparoscopic hepatectomies combined with portahepatis lymphadenectomy are considered challenging operations, and there is relatively paucity of high-quality literature on the safety profile and outcome of these surgeries. Mayo Clinic is a high-volume center for minimally invasive liver surgeries, and this study was aimed to describe the Mayo Clinic experience with laparoscopic liver resections for both gallbladder cancer and intrahepatic cholangiocarcinomas, and to specifically ascertain their safety and oncological adequacy in a high-volume quaternary center. In order to perform this study, we looked back in the Department of Surgery database and found 33 cases in between January 2016 and December 2020 of curative intent laparoscopic liver resections for intrahepatic cholangiocarcinoma or gallbladder cancer, whether as a one-stage definitive radical cholecystectomy or as a completion hepatectomy and lymphadenectomy for incidental gallbladder cancer finding after a simple cholecystectomy. We have reviewed the patient chart and assessed clinical pathological characteristics, imaging, operative details, and outcomes of these patients. We then analyzed the data with specific emphasis on resection margins, portahepatis lymphadenectomy, adequacy, and postoperative complications. Moving on to results. As mentioned, our cohort included 33 patients with gallbladder cancer or intrahepatic cholangiocarcinomas who underwent curative intent laparoscopic liver resection with or without portahepatis lymphadenectomy in Mayo Clinic between January 2016 and December 2020. The median age of patients was 65 with a standard deviation of 11.8 years. Unfortunately, not all the cases underwent portahepatis lymphadenectomy. The ones that did not underwent portahepatis lymphadenectomy were mainly the earlier cases prior to the AJCC 8th edition publishing. 6 patients, which were 18% of our cohort, underwent major liver resection, defined as resection of 3 or more segments with portahepatis lymphadenectomy. 14 patients, which were 42% of our cohort, underwent minor liver resections with portahepatis lymphadenectomy, while 5 patients, which were 16% of our cohort, underwent major liver resection, and 8 patients, which were 24% of our cohort, underwent minor liver resections without portal lymphadenectomy. The mean operative time was 193 minutes with a range of 83 to 881 minutes, and the mean estimated blood loss was 250 cc's with a range of 25 to 1700 cc's. There were only 2 conversions to laparotomy due to failure to progress. 19 patients, which were 58% of our cohort, had no postoperative complications. 5 patients, which were 15% of our cohort, had minor postoperative complication, defined as Clavien-Dindo score of equal or below 2, and 9 patients, which were 25% of our cohort, had a major postoperative complication defined as Clavien-Dinto score of 3 and above, including one postoperative mortality due to portal vein thrombosis leading to a fatal liver failure. The median in-hospital length of stay was 3 days with a range of 1 to 39 days. On pathology, the mean tumor size was 36.5 millimeter with a range of 15 to 150 millimeter, and resection margins were negative in all specimens. Amongst the patients who underwent portal hepatis lymphadenectomy, the mean number of harvested lymph nodes was 4.5 with a range of 1 to 19, and 8%, which were 40% of the total patient who underwent portal hepatis lymphadenectomy, have met the AJCC 8 edition staging manual cutoff of at least 6 harvested lymph nodes. After analyzing the cases, we can safely say that when done by experienced minimal invasive liver surgeon in a high volume center, laparoscopic liver resection for gallbladder cancer and intrahepatic cholangiocarcinomas are both feasible, safe, and oncologically appropriate, and therefore could and should be applied in selected cases. While operative time, estimated blood loss, and postoperative complication profiles are at least comparable to historic open control, the in-hospital length of stay is shorter. When done by experienced minimal invasive HPB surgeons, laparoscopic liver resections for these diseases seem to provide short-term benefits without compromising on oncological principles. As in open surgeries, an effort should be made to meet the AJCC 8th edition recommendation of at least 6 harvested lymph nodes for adequate tumor staging. Although not assessed in the study, it has been published before that laparoscopic liver resection for intrahepatic cholangiocarcinomas and gallbladder cancers can be performed with no difference in long-term outcome compared with those who undergo conventional open liver resections. These days, we are working on a retrospective study to compare these cases with open surgeries control. Thank you all for your listening. I will be happy to take some questions now.